again, I am Alexa Tinsley. I am the Director of Programs here at Jett Foundation. I want to thank you all for being here today. We are here with Dr. Kent Williams. He's going to talk to us about the gastrointestinal, if I could talk, ins and outs today. If you don't already know him, he is very well known in the space, but Dr. Kent Williams is an attending pediatric gastroenterologist at Nationwide Children's, and he is also the medical director of endoscopy. He is an associate professor of clinical pediatrics at the Ohio State University College of Medicine. And his specific interests involve pediatric gastroenterology with a special interest in GI disorders in children. So he has been at presentations with PPMD. I saw him speak this past year. I saw him speak a few years ago, which is where I got the idea to reach out to him. So we're very excited to have him here today. Before we get started, I do just want to mention a few things. This webinar is being recorded, so if for any reason you have to hop off, if there's anybody that you know wanted to watch this webinar and wasn't able to, we will have it recorded. This is being streamed to Facebook, so it will be on Facebook, but it'll also be on our YouTube for later as well. We will have a live question and answer session at the end. If you could please use, there is a Q&A box for me, the bottom right hand of my screen. It has a little, I think it's 2 boxes with Q&A and a question mark in there. We do primarily utilize that box for any questions that come through. So if you have questions during the presentation, please put them in that box. We do try to get to our Facebook questions, and we do try to monitor the chat to see if any questions come through there. But we do primarily use that box to answer those questions. There is also closed captioning available. There is also a CC button at the bottom of your screen. You can go ahead and click that, and you should be able to get subtitles for you if you need them. So with that, I'm going to go ahead and go off screen and hand it off to Dr. Williams.
Thank you. So today I'm going to be talking about the gastrointestinal ins and outs. Next slide. Primarily, I was going to touch a little bit on the things that I see in our neuromuscular clinic here at Nationwide Children's in Columbus, Ohio. The 2 top things that I am consistently consulted about in the clinic is trying to have a healthy nutritional state or status and a good bowel routine. Next slide. So nutritional status is very important in young men with Duchenne, because at times there are various reasons why they try to limit or not able to eat enough. And the problem is, if you don't get enough energy, you're going to start having basically a breakdown of muscle, a breakdown of fat and everything that is needed to have a healthy body. And the more you reduce, the more malnutrition you have, and it just becomes a vicious cycle. You get less appetite and it just continues to go in circles. Next slide. So I encourage everyone to pay close attention to their weights. Now, early on, everybody seems to be very concerned, of course, about being on steroids for the treatment of Duchenne's and gaining too much weight. But then at some point, there always seems to be a kind of an inflection point where a person starts to lose weight. And at first, everyone's kind of like happy, we're doing okay, we're losing weight like we've been told to do for years. But that's actually the time I start getting kind of concerned, because if we're not really trying to lose weight and we're losing weight, then I start worrying about why, and if we're starting to get into that vicious cycle of being malnourished. Because you can be overweight, but if you lost a lot of weight, you can still be malnourished, and that will speed up the breakdown of things. Next. So remember, inadequate nutrition means you have impaired function. Not only impaired function of bodily muscles, but also you may not be able to concentrate as well, sleep as well, and those things. Next. So this really affects the quality of life. And then the things I really start asking about in this time, when we start losing weight and people are starting to be a little bit more concerned about, is how much time you spending on eating. Are we spending more than 30 minutes? And also, for the caretakers, for moms and dads and caretakers, are you starting to just like, is eating starting to take a top priority? You're very concerned that you're that your son or daughter is not eating enough, and that becomes more of a top priority and worry. Next. And then the other thing that we usually get is constipation. Now, constipation can affect everywhere along the whole spectrum. And one study was done, half of young boys in a Duchenne clinic met the criteria for constipation. And the constipation wasn't associated with age or ability. It could happen at any time. So I feel like bowel regimens should be addressed at all times because they can have a lot of significant complications later in life. And of those who actually met the criteria of that half, one half of those aren't being treated. So that means 1/4, roughly, of young men with Duchenne are being left untreated and having constipation. Now, they may be not severe at the time when they're younger, but as they get older, we start to get very concerned that this may lead to some significant constipation issues and loss of function of the colon. Next. Particularly, we've seen in our institution and what's been published in other institutions is that there can be life-threatening bowel complications later in life in young men with Duchenne. There was a case series done of 4 adults that all presented with very dilated colons, very dilated stomach, a lot of abdominal pain. And the thing they had in common among them is they all had years of chronic constipation. Next. So here's a picture of an x-ray from a young man at our institution that fits this criteria. He was only 15. And what you're seeing here is his whole stomach is actually, came in severely dilated, looked like a big medicine ball in his stomach, and it was all his colon just completely blown up. Next. He had years of chronic constipation, problems of controlling his bowels. Next. And because of the way he was presenting, we decided to give him a colostomy. And that solved all his problems that he was having with abdominal distension. And actually, he's doing quite well now. So the next slide here is sort of what my approach has always been of trying to treat every patient, particularly young men with Duchenne. A good physician treats the disease. We can treat constipation, but the problem is a great physician treats the patient who has the disease. So if I treat somebody for, let's say, malnutrition, if I treat somebody who's not able to eat well, if I treat somebody who has constipation with the standard therapies, we need to think about how is that going to affect life and try to do it in a way that actually improves the quality of life. Next. So in muscular dystrophy, nutrition, my goals are I'm trying to reduce the time and effort spent on eating. I'm trying to reduce the concern. And the biggest thing is I want to keep people eating. I want them to eat by mouth, but I also want to improve their function. Again, malnutrition impairs function. Next. In bowel patterns, I want to improve independent function. Not that you're going to have to worry about somebody always being around in case you need to go to the bathroom. I want to be able to have a young man be able to leave the house without concerns of having a bathroom. And the biggest thing that we find treating constipation is it improves your eating. People always know already about the ins and outs of life. Whatever goes in must come out. So a lot of times when people start having bowel issues, they start limiting what they eat. And same with urination. If they were worried about urinating, they're going to stop limiting what they drink. So by controlling these things, by helping with these things, you're now allowing someone, basically what I got told by a young man who we did help was I can eat anything I want, anytime I want. Next. So for the bowel regimen and what I was asked to talk to you about today, what are your options? Well, dietary changes, definitely. You can try to increase your foods that you eat that have high caloric density. There's also foods that you can have with fiber that will help with your uh, with passing stool also. But I would say most guys actually probably need to be on some kind of stool softener too, because you really want to have a good bowel regimen all your life to avoid any of those complications later in life. And I think a stool softener is a good way of doing that. Don't want to make things too soft, but just keep it soft so it's easy for the muscles to work and push it out. Now, if you're having problems getting it out, there are laxative stimulants, senna, bisacodyl, and actually motegrity or prucalopride. And if those you can take by mouth, and there are, but the problem is when you take things by mouth, I don't know when it's going to affect you. You may be out somewhere when all of a sudden you get a big urge or whatever. Suppositories are a good option if you just need help from time to time to make sure you're keeping the last part of your colon cleaned out. And the same with enemas. I do have young men who decide to use enemas 2, 3 times a week, always making sure that last part of the colon is cleared out and they don't have to worry about having accidents. Now, as things go on and things progress, a lot of guys, though, have problems with really getting the stools out and even doing frequent enemas and suppositories. In these, we offer options of cecostomy, where we make a connection to the first part of your colon, flush things through, and colostomies, where we basically take the last part of the colon and put it to a bag. And then in some kids, and I'll talk about one here in a little bit, an ileostomy, where the colon is basically so dilated, having so many problems that we just bypass the colon altogether. Now, in kids with, now the other option, I do tell people right now we don't know 100% long-term use of stimulants where that may increase muscle loss. We don't know. Right now, the feeling is probably not, but I do mention it to people if you're going to be on this for years. Next. Cecostomies are not a really good option. I've had one young man that I've given a cecostomy to. We ended up going to colostomy eventually. And I've had a couple of young men come to me from other institutions that had cecostomies, and we ended up going to colostomy with them also, because cecostomy requires you to sit on the toilet for at least 30 minutes, more likely like an hour. And so if you don't have this ability, which over time you lose, to be able to sit on the toilet, it really actually makes things more difficult. Next. So the colostomy option has always been out there. It's not something new that we're just doing here for young men with Duchenne's. It's been out there for years. They've been doing it a lot in young children with possibly with spinal cord malformations and things. But an area where it's really gotten a lot of notice in the last few years, particularly out of a group in the UK, is those who've had spinal cord injuries later in life, either from motor vehicle accidents, falls, and things like that. And what they looked at was 27 patients, 26 men, one woman, ages 44 to 79, that they gave a colostomy to because they were struggling to maintain their bowel regimens. And they showed that they had a significant improvement of the quality of life. What they found was, on average, for these 27 patients, they went from average bowel time, which means not just trying to have a bowel movement, but how often do you think about it? How often does it affect your daily routine or your daily activities? And it went from almost 2 hours down to 13 minutes per day. There were some complications. For a few of them, they had some wound dehiscence. Things kind of the skin fell apart from the colostomy a little bit. And they did experience some late complications where the stroma, where basically the colon kind of, but these are all minor complications that were easily addressed. Now, the resistance colostomy, of course, not only from the patients, everybody's like, oh, I don't want to poop in a bag, but it also comes from physicians, because basically sort of the mentality is that's a last ditch effort. But what they found in the UK is once people started getting this done, particularly in the, like I said, in the spinal cord injury population, is the patients started asking for it right up front. Next slide. So typically this is a pyramid of kind of like how physicians think about it. Again, you start with sort of the lower pyramid. Everyone should be, just diet. You start with some medications, then you may do some stimulants, and then you go on to possibly enemas, suppositories, and then the surgical options are at the tip of the pyramid. We don't really want to offer those unless they really are struggling and really have failed everything else. What they found was when they compared what the practitioner was thinking compared to the patients, were the patients were wanting it right away. They didn't want to wait on times. And I think that, again, this goes back to what I was talking about, is treat the person with the condition. I can give you medications, I can treat constipation, I can soften stools, I can stimulate bowel movements. But is that what is needed in this situation? And someone who can't get to the toilet on time, to a young man who has to be transferred, and there's been many stories in our clinic of someone being dropped in a transfer, breaking a hip, breaking a femur, and those things. When we go talk about colostomies, people are a lot more open to it than people realize. Next slide. In our institution, we've done it in about, I believe, 8 patients here. The only complications we've had is, one, we had a little bit of dehiscence or a little bit of a fistula in one. It wasn't real severe. We were trying to make plans to revise it, but because of his respiratory status worsening, we weren't able to. But they still appreciated having the colostomy, and that it really made it easier to care for his bowel regimens. They didn't have to transfer him, especially when he was starting to have a lot of infections, a lot of problems with his pulmonary status. One young man, we put a colostomy in, and he still continued to have this really dilated small bowel. And we put in an ileostomy. And this is an old slide, 1.5 months. It's now about 8 months out, and he is doing fantastic. He went from being hospitalized with obstructions about once a month to he hasn't had an obstruction since the ileostomy went in. Next slide. And that's pretty much it for the talk I had prepared today. I would love to have some questions and discussion and anything I can help answer.
Yeah, thank you so much. I think, my life is, I was an MDA family care specialist, so I did camp, and we still do camp with Camp Promise, and I think I actually remember something that you said during one of your presentations was like, we all poop. We got to talk about poop, right? So I think I really appreciate you putting together this presentation and sharing it with us. I think, to your point too, colostomies are kind of seen as that last resort and scary, and so I appreciate you sharing more about that, and that it's not just a last ditch effort, and that I think another misconception is that you can't eat once you have one, which just, is not true. Can you also, just to the G tube piece, talk a little bit about, eating with a G tube as well? Because I think that's also a common misconception.
Yeah, G tube actually, I mean, between the two procedures, the G tube is easier placed than a colostomy. And G tubes, there's the only reason I put a G tube in somebody or recommend a G tube going in is to improve quality of life. It's not to take away eating. It's not to, and where are my goals for quality of life? One, make sure we got plenty of nutrition going in. As you start to lose function of your arms and you can't feed yourself, you're dependent upon others. Plus, your jaw muscles start to also struggle and things like that. And it's a slow process. It's a process that people just don't even really recognize from day to day. But if you go back, that's why that growth chart is really important, because you just see that gradual decline down. And what I don't want is someone to come to me when they're at the end of that decline, when they're basically at the very bottom. I'd rather them come to me just past the peak a little bit, and we start making adjustments and try to flatten it out. Because by using a G tube, you give extra fluid if we need to, if you get dehydrated when you're sick. We can give just extra nutrition, not take over your nutrition, just give a little extra, make sure you're getting all the minerals and vitamins, and then allow you to eat and drink whatever you want by mouth, as long as you're able to tolerate it. And I gotta be honest with you, in my clinic, If we get someone who's choking and gagging, we don't get a lot of swallow studies because what we're going to do with it, unless it's affecting your breathing or other things. My goal, I want you to live your life. I want you to be able to swallow. I want you to the food you want, and we just have a frank discussion. You're at risk. You make the decision how you want to live your life, and by maintaining nutrition, sometimes I've had young men who couldn't swallow well. We put a G tube in, they get the energy back, and all of a sudden they're able to eat more by mouth than what they would without the G tube. So again, the G tube is not, I'm wanting to improve your quality of life. I'm not just wanting to extend life. We're looking for reasons other than just giving you nutrition.
Absolutely. I really appreciate you making that clarification. We do have a question. With colostomies, when they're not necessarily needed medically, but a patient decides to have one elective to help an individual have easier bowel movements and improved care requirements, allowing better independence, etc. Have you found that medical institutions and insurers agree to provide that procedure, or are there some things that some people might need to prepare for when asking for that electively?
Yeah, no, that's a great question. I've had people after seeing me at PPMD or consulting with me, and I send them back to their local institution to talk to somebody. They will meet a surgeon, and the surgeon will say, "Oh, we don't electively do this. It has to be a necessity." Um, Usually in those situations, I'll provide them with those papers that I just went over. Um, I don't see a lot of. I haven't come across problems with insurance unless the person was wanting the procedure done, let's say, like at our institution, and there was someone local that could do it. That becomes more of an insurance issue. Again, the reason I put in the lecture about that there is only not only resistance from the families and the patients, but there's resistance within the medical fields too. So that's definitely out there. But I think if you're able to find someone, and I'll be honest with you, if the doctor isn't listening to you, like, I want to do this to improve my quality of life, and here are the reasons, find you another doctor. It would be my guess, quite
Yeah.
honestly. You want somebody who's going to
Second
listen.
opinions are
Yeah,
always good in those situations. Second and
yeah,
third, depending on the situation, right?
yeah, yeah. We do it here. There's a whole host of new things with colorectal providers. You just may need to find the right provider. The other people that help out a lot. Now, if you're an adult, sometimes it's tough because I treat only pediatrics. But the people I would talk to get to advocate for you are physical medicine physicians, PMR. Physical medicine physicians, if you're an adult, they're used to dealing with patients not only of Duchenne's, but these spinal cord injury patients, patients with cerebral palsy, maybe, other patients of special needs that aren't ambulating, aren't walking around. So they may be very good to advocate for you with another doctor too, if someone comes back. So I've never done that before.
Yeah, absolutely. How often does a colostomy bag need to be checked, emptied, changed, etc.?
Average once a day. I got one young man, one of the first ones we put it in, is about every 3 days, once a week. I didn't even know that was even possible, but because it's still poop going into it. It's not like he's constipated, but yeah, no, it just varies. But I would say on average daily, and it takes just a few minutes to change. So that's why all of a sudden, you're going from in my clinic. I ask the questions like, how once you decide you need to have a bowel movement or it's in your routine, what do you do? How long does it take you to get from where you are sitting to the toilet? How do you get from there to the toilet? Do you use a toilet? Do you use a chair? Do you just go in the bed and all those things and go over the hours? And I start collecting, timing it up and stuff. Because with a colostomy, it really does reduce the amount of time. And what we find too is you can have a colostomy and no one's ever going to know it. One of my closest friends who we've putting together a team right now to talk about this, she's a social worker. I knew her for 3 years before I approached her and asked her if she'd want to do it because I found out she was talking to young men who had Crohn's disease complications and getting colostomies. I said, "Yeah, I would love to have you on my team." And she goes, "Well, I have a colostomy, right?" I said, "No." I had no idea. She lifts her shirt up. there it is. I'd known her for 3 years, never even knew. So, colostomies people get kind of concerned about, but everybody in the room could have one, you wouldn't even know.
And I think that too, I think sometimes there's a lot of fear around like, oh my gosh, I'm not going to know how to do it. But, through my experience with nursing, and I'm sure you can also back this up, before you leave the hospital, if you were to get that procedure, they're going to walk you through what that looks like, make sure that you know how to do it before you go home. And if for any reason you have questions or aren't sure about what that looks like before you leave, ask the questions. But, I think it's easier than most people realize.
Changing a bag for a colostomy, I would say, and if I'm wrong, someone please shout out me, it would be easier than using a Hoyer lift.
I would agree. Absolutely. Let's see. If anybody has any other questions, please go ahead and ask them now. Also, if you have any questions after the fact, Dr. Williams did have his email. I had it up, but I can always send it to you as well. Feel free to reach out to me. I can get it to him. If you are watching this as a recording and have questions, same thing. Dr. Williams, thank you again for doing this. I think it's so important and such an important topic, but sometimes misunderstood topic. So I really appreciate you taking time out of your day to help bring more knowledge to the community. For everybody watching, we do have a survey that we will send out. So please take a few minutes. The only way we can improve is through our surveys and feedback. So we appreciate all of you for being here. Dr. Williams, thank you again for being here. And we will see you next time. Have a great day, everybody.